So yeah, I'm John Guilfoose, one of the clinicians here at Ruby in Morgantown, and I realize I use the word clinician as an excuse. I say I'm a clinician, implying I don't know any epidemiology. So if there's questions on that, I get to um, say I don't know. I would like to start out the session. Well, actually, disclaimer: this is a lecture that I give for the WV Hamp scholars because W Hamp is also doing hepatitis B as well. It takes me about a half hour to get through. um, Hep B is a heavy topic, but can be overviewed very well. And so I hope that's what we'll accomplish today. But I'd start off by honestly asking for participation from anybody on, if anyone has particular questions about hepatitis B or conundrums they faced or challenges when dealing with hepatitis B, so I can make sure I address it as we go along, make the slides more pertinent. And if none, that's also okay. If it's a shy group. All right, we will take silence as shy group. And um, the first couple slides are honestly, in my mind, all you need to know. If you know the first couple slides, then I'll be perfectly happy that we've communicated well. So I think we obviously, this is the Hep C echo, and so we kind of have done a hepatitis C curriculum many times over, and a lot of us are very familiar with hepatitis C and its mechanisms of transmission, treatment, complications, natural history, etc. And what I want to do is emphasize, how is hepatitis B different? So you don't have to memorize everything twice, just sort of memorize the differences between the two. A couple of the things to remember is that hepatitis B is very efficiently transmitted sexually. So remember, for hepatitis C, we in general don't think of it as a sexually transmitted infection outside of the setting of HIV positive, in the setting of men who have sex with men. So MSM, HIV positive, my goodness, hepatitis C is certainly an STI. But otherwise, it's really inefficiently transmitted. Now, hepatitis B is very different, and it's quite efficiently transmitted sexually. Number one difference. Number two, very high rate of transmission mother to child, and that's again different than that low 5% transmission in mother to child for hepatitis C. It's much higher for hepatitis B. I can't give you a number because we don't let it happen. So we have a beautiful prevention strategies to prevent mother-child transmission. So that's one of the great parts, is we can really interfere with that natural history. And I can only remember in the past, 15, 20 years, seeing one child acquire hepatitis B because we've had really good intervention strategies, sort of similar to HIV, where we know the natural history says a good high percentage will get mother-child transmission, but we have good interventions. Same for Hep B. Just Hep C is the only straggler there. We don't have anything for Hep C. Effective vaccine available. So in other words, this talk, I shouldn't even have to give it, right? Hepatitis B should be gone and a thing of history, because we have a beautiful vaccine that should take care of it. But you need 100% uptake, and we all know that dream. So, but hepatitis B vaccine, I would love to not give this talk someday because everyone is immune to it. All right. A lot of the confusions and stuff come from labs with hepatitis B. Kind of the two tricky parts of Hep B is the labs and its natural history of being a DNA virus. So, but if we talk about the lab, I'll go through those and try to be a lumper. I'll try to lump them together so you only have to memorize three things. The labs basically tell you immune, exposed, or active. And that's kind of a combination of those are the three answers you can get from a whole bunch of complicated antigen and antibody studies. Some cool natural history stuff. So hepatitis B, when you acquire it as an adult, you have a 90% chance of winning. So that's awesome. How does that compare to hepatitis C? We don't know. Maybe in the realm of 10. It depends how old the textbook is. Old textbooks say 10% of people cleared Hep C. More modern textbooks say 30 to 40% of people clear hepatitis C on their own. That's without treatment. Whereas Hep B, you have a higher chance of becoming immune to it after natural exposure. But there's a downside that I'll talk about. And that's really the top part. The hepatitis B is a DNA virus. Again, we all have familiarity with herpes viruses. We know that once you get chicken pox, you get VZV forever, and it can wake up and cause trouble. Same with EBV, CMV, HSV1 and 2. These are DNA viruses. Hepatitis B is not a herpes virus, but it's a DNA virus. And once you get it, you never really get rid of it. Your immune system can control it, but issues can arise if you really, really compromise the immune system. And even the most immune patient can reactivate because that virus never really leaves you. It hangs out in little microchromosomes in your hepatocytes, and it's not a retrovirus like HIV, where it actually incorporates into your genome, but it makes its own little chromosomes, and as far as we currently know, it's not curable. Yeah, and I'll talk about why that becomes an issue on occasion. And unlike hepatitis C, it can flare up periodically, and a flare, for all intents and purposes, looks like a mini acute Hep B, and it's indistinguishable, and you can even have IgM positivity to your core. So you have to. Only way you can tell someone has a flare is because you knew they already had Hep B. Otherwise, it'll look like acute Hep B again, and that can happen during all sorts of situations we'll talk about. Treatment is remember, hepatitis C treatment is treat everybody. Let's treat everybody. As long as you can get the treatment and you're not going to get reinfected, let's get you cured. That's Hep C. For Hep B, we go through a very complicated algorithm of who needs treatment and who doesn't. The generic concept of it is treat people who are having damage done from the virus, which is not everybody. And then the last difference is Hep B is way more oncogenic. So hepatitis B is one of the genuine oncogenic viruses. Remember, hepatitis C causes cancer, liver cancer, through scar tissue and inflammation. But hepatitis B does that and then raises you to an oncogenic level with a little oncogene that can make you progress to liver cancer much more rapidly, even without scar tissue. So remember, with hepatitis C, we always say, let's screen our F3, F4 scar tissue patients for hepatocellular carcinoma. With hepatitis B, we even have to screen our F0, F1, and F2s. So it doesn't. There's no scar tissue free group that you can bypass HCC screening. So all right. And basically, if you know all that, you can tune out, because I'm going to say that same stuff more slowly and with prettier slides, but that's all you need to know. So yeah, there's just a picture that talks about all the stuff, the surface antigen, and we never see the core antigen. Remember, if you're ever ordering in labs, you can't order a core antigen because the core antigen doesn't circulate. It's hanging out in the liver cell. So you have to order the antibody against the core. So the anti-core. But with the surface antigen that circulates in large quantities, and you can check an antibody against it as well. The E antigen, think about as representing almost like an antigen version of a PCR. So it tends to be positive during active disease. And if you develop an antibody against the E antigen, it tends to be a good indication that you're starting to clear. It's heading the right way. These two things are the other gene products that you probably need to know about just a little bit. And the second one is the one that's an oncogene. So the hepatitis B oncogene basically revs up your cellular machinery and can lead you to developing cancer. So what are the other genuinely oncogenic viruses? HPV. HPV, vaccinable, thankfully. EBV, Epstein-Barr virus, nasty virus. Wish we had a vaccine for it. We don't. Hep B, but even though remember, Hep C can do it too, but not through an oncogene. It's through scar tissue. So, and again, this quirky little top part, this DNA polymerase. Why do I have that up here? Why is it worth knowing about? It's a weird virus that copies itself. Remember, we as eukaryotes and even most logical viruses and bacteria want to copy their genome in high fidelity, so they'll copy DNA to DNA. But for some reason, that hepatitis B virus says I'm gonna have an intermediate with RNA. So I copy DNA to RNA and then back to DNA, which is an odd phenomenon. It leads to a lot of errors and replication, which I guess if you have 100 billion children a day, you don't care if some of them don't make it. But that's sort of the hep B parenting 101. But from a clinician standpoint, again, that word clinician, I take advantage of that fact because when things copy from RNA to DNA, that's a potential area we can intervene with antiretrovirals. So even though this is not a retrovirus, it's a DNA virus, it copies itself a little bit like HIV. So we can use some of our HIV medications to interfere with its cellular machinery and inhibit its proliferation. So it's pretty cool. Thank goodness it does that. Otherwise, we wouldn't have any treatments for it. Transmissions similar to hepatitis C, except for sex being more common. And this is not foodborne. So remember, foodborne is hepatitis A and E, whereas B is really fluids. So kind of any fluids can do it. And it's about as common as HIV in the US. It's less common than hep C. And yeah, that's about what that says on here. Now, and again, similar number of new infections per year as hep C, but most people clear it. So again, 90% will clear it on their own. But again, the bad part is they're still going to store that microchromosomes in their hepatocytes and could run into trouble in the future. And I'll talk about why. Same risk factors for hep C, so nothing new or novel I need to talk about. And Dr. Feinberg gave me this slide, and basically it's, because the transmission mechanisms mirror those of hepatitis C and largely reflect, injection drug use with a lack of using clean needles and sharing works, et cetera. It's basically the epidemiologic curves trace that of hepatitis C. So it's kind of a bummer. And hep B is really high too in West Virginia. And again, tends to be the same places. Couple parts of quirky history that it's kind of interesting to know. So if you were to travel around the world, you would be like, wow, the US doesn't even have a problem from hepatitis B standpoint. And that's because some areas of the world have an incredibly high burden of hepatitis B. And there it's not from drug use or sex, it's actually from mother to child transmission. So the most common referral patient I see for hepatitis B is a recent immigrant from Asia or Africa who got serologic testing done and found out in their mid-20s or whenever they came to school that they have hepatitis B. And you talk to them and they never had any symptoms of acute hepatitis. They've never had any symptoms at all. And they don't really have any risk factors, no behavioral risk factors, nothing like that, except for coming from an endemic country. And what probably happened is that mom had unrecognized hep B and passed it on. So vertical transmission worldwide is by far the most common mechanism of transmission. And it just so happens that if you're infected in the perinatal period, you don't tend to have symptoms until really late. So you can still get cirrhosis, but you don't ever get the acute hep B part. And they don't tend to clear. So that 90% clearance to 95% clearance is really if you're exposed as an adult. So that's sort of the exact opposite. If you're exposed as an adult, you're more likely to have an acute hepatitis. So you'll have some jaundiced illness, but you're more likely to clear. So, given the two, I guess you'd rather be exposed as an adult because you're likely to clear it, but you're going to suffer for a little bit. So, again, what can hepatitis B do? Kind of everything that hepatitis C can do. It can affect you subclinically. You can have an acute viral hepatitis, which we'll talk about. It can actually be bad enough to send you to liver failure. We actually had one of these just last month, and that's always scary. And it can progress to chronic liver disease, including cirrhosis. And we kind of talked about the cancer risk factors already a bunch of times, but I don't want to forget about that at all. And again, that's scar tissue independent. So what does an acute viral hepatitis look like? It usually starts off as feeling like a lousy stomach flu, and you might not attribute it particularly to the liver until some signs and symptoms of jaundice jaundiceness appears. So that can be a scleral icterus, some jaundice discoloration of the skin, or some dark colored urine or clay colored stools, kind of all the above. and that hits you after a week or so of starting to feel lousy. And I don't want to I don't want to minimize how bad people with acute hepatitis often feel. They often get admitted just because of like, and I try to get symptoms out of them. I'm like, what exactly do you feel? And the answer is, I just feel awful. They just feel awful. They have nothing worse than chronic nausea, no appetite, weight loss, but it's not a toxic patient. This isn't somebody who looks like they have, MRSA bacteremia or anything like that. So, but they just have, don't want to eat, may have, again, it's a very immunoactivating illness. So you can have, your joint aches and pains the cytokines cause and stuff like that. But a lot of times it's just fatigue and feeling yuck, malaise, and no appetite. All right. So the not fun hepatitis B serologies. What we really want to do is be a lumper with these and sort of remember what they say. So certain ones suggest active infection. Certain ones suggest prior exposure, and that's it. And then others, actually one in particular, indicates that you're cured and on your way towards being a good spot. So the surface antigen is one of the ones that that's just a gene product produced in large quantities. That's a part of the surface coating of the virus, and they're an active disease. So active disease marker. The E antigen is there, an active disease marker, and the DNA is there as an active disease marker. I don't have it on this graph, but DNA would trace the E antigen very nicely. And then you start developing some evidence of immune control. That's often the anti-E and the core antibodies. And remember, the core antibody is not protective. It's just a marker. And so core antibody is present when you've had infection. That's either present and ongoing or cleared. So the core antibody is not protective. It's almost analogous to the Hep C antibody. It's just a marker of infection. We can subdivide the core antibody into IgM and IgG. I don't find them awfully helpful because there's a lot of situations, even when people are chronic infection, where their IgM is still positive. So while this graph really trumpets the importance of the IgM for diagnosing core, in clinical reality, I've not found it to be able to differentiate nearly that well. The only time it's really helpful if you have isolated IgM core, then it probably is acute if you don't have the IgG. But if you have both, I can't tell you if it's a acute infection or a flare. The only antibody that really tells you that you're cleared, like genuinely cleared and immune and protected, is the surface antibody. And that's the one that we try to induce with a vaccine. And that's one that we hope to see after natural infection. So the antibody to the surface antigen, The antibody to the E antigen and the antibody to the core don't tell us with certainty that a person does not have active or ongoing disease. So it's really the only one that's a marker of immunity is that surface antibody, and that's the one we want to see. So the carrier state is basically anything that says I have prior exposure or active disease, and I don't have that antibody to the surface antigen. That's every other derivative thereof would be one of those two answers. And you can see the natural history. What happens is in acute hepatitis B, you expect to see those active markers of infection, the E antigen, the DNA, and the surface antigen come up and then gradually clear. And then those markers of clearance go up. And the one you really, really want to see is this one, the antibody against the surface antigen. What happens in situations where you get chronic infection? That never happens. You never get the clearance of those active markers of replication. So your E antigen persists, your DNA persists, your surface antigen persists. And while you'll get anti-core and you might get anti-E, you'll never get the antibody to the surface antigen. And that's the bummer. And that's why you get your chronic hepatitis, your chronic active hepatitis. And this is not a slide I'm going to read to you, but there's like endlessly Googleable, lists like this where if you draw your various studies, you can fit people into these groups. But I swear these tic-tac-toe boards make it more complicated than it is. Just remember, if you have the antibody against the surface antigen, you're all good. You're all good. If you have any of the other antibodies, you probably were exposed. And if you have the surface antigen or the DNA positive, you have active disease. So try to just lump them into, what does it tell you? And be aware from that perspective. One question that comes up on occasion is isolated core antibodies. Remember, I said that one happens during prior exposure, so you would not expect this from a vaccinated person. Remember, when you're vaccinating somebody for Hep B, you're literally giving them surface antigen. You're giving them surface antigen, which, by the way, be careful. If you vaccinate somebody for Hep B, don't go and check the surface antigen the next day or even the next month, because we've done that by accident. Just clicked on the wrong button in our EMR, and what you'll find is will scare the dickens out of you because it looks like the patient has acute Hep B. You're like, oh my God, the surface antigen is positive. No, you just gave it to the patient with the vaccine. Not dangerous. Remember, that's just a non-replicating piece of protein. So if you have isolated core, it means you've had prior exposure, most likely. And that's the most common answer. Very, very rarely can it be a false positive. Have I seen it? Yes. How many times have I seen it in 20 some odd years? Once. So in general, it's not the common answer. It's the most common thing patients hope it is. They all want it to be a false positive. But it's often just not. How would you prove that? You basically order the same study again, the hepatitis core antibody from another lab that does testing for the different modality. And that's the only way you can test that theory. And if it's not, it's positive at your lab, but not in another lab, and you have no risk factors and none of your other markers are there, then you can call it false positive. But sometimes if you caught somebody super early on, so remember way back here, before the rest of the core antibodies are detectable. So right when the surface antigen drops down, before your anti-surface antibody comes up, there's this window period, and you could have isolated core in that scenario. I can't say I've ever seen that, truly. A real common one is that you actually had natural infection and you're immune, but your immunity it was so long ago that your antibody levels are really low, and it records as not immune. So you just have isolated core. The way to test this theory is to give someone a vaccine. So if you have isolated core, and my colleague and best friend and partner does this routinely. Kaylee does this routinely. She gives people a vaccine when they have isolated core and then reassays their antibody response in about a month. And a lot of times they're immune. And it's just something where their immunity was no longer detectable. And you couldn't detect that without giving them a little booster and sort of seeing what happens. The last thing it can mean is that they have some reason that they're just not showing you any other replication markers. And the most common reason that's there is from having Hep C co-infection. So remember, hepatitis C is actually usually the dominant virus in co-infected people and can suppress the replication of the surface antigen and the DNA and all that other stuff. And so it can almost make hepatitis B hidden, where the only thing you can find is that core antibody hanging out. So you want to always make sure you don't have co-infection. I think that's the most common answer I see, followed by prior remote immunity with just decayed evidence, which you can unmask with vaccination. So what do we do in these isolated core antibody patients? We collect more data. You want to check the E antibody and antigen. If either of those are positive, that definitely tells you it's not a false positive. You're like, all right, it's not false positive. And you want to do the DNA amplification. And so just collect more data, fill in your data sets, and then you can figure out what to do from there. Never hurts to give the vaccine, but in general, if you have a chronically infected person who just is being suppressed by Hep C, it's not going to help them. It's not going to hurt them. It's not going to help them. So remember, being a DNA virus, the one part of the natural history that is different and kind of worse, I would say, than hepatitis C is that this virus can you're never really cleared of it. And it can lead to this concept of flares and reactivation, which we don't see with Hep C. And I'll talk more about that in a little bit. And I already talked about its extra cancer risk as well. Now, for Hep C, we always talk about it being a systemic infection. Even though it's a liver disease, it causes such immune activation that we see symptoms all over the place. Largely, these are autoimmune in nature and inflammatory in nature. And I could copy and paste the hepatitis C stuff onto the hepatitis B stuff. It's basically rheumatologic whatnot. So if you irritate the immune system long enough, it starts having autoimmunity. And it's interesting. A lot of the autoimmunity in hepatitis B tends to be directed towards the blood vessels. even more so than Hep C. Blood vessels and nerves. So, but same concept. There's not an autoimmune disease that I would put past a potential relation to Hep B. Again, the concept is just you flog the immune system with an incurable viral infection long enough, and it accidentally makes some autoantibodies. At least that's the dumbed down clinician version. Once again, all right. So treatment. So this is a kind of a different Hep C. Again, Hep C, you want to just treat everybody. You want to rush in. You want to get them treated early. With Hep B, you want to hold tight. Again, when I first diagnosed someone with Hep B, I just want to try to get a sense of where they are. When were their risk factors? Is this acute? And if it's at all something where the risk factor was recent, you want to just sit back and wait. Because remember, natural history says 90+% of those people, 95%, will become immune despite anything you do. So, and that's wonderful. You almost don't want to mess with that success rate. I can't make it more likely. I could probably make it less likely, but I just don't want to do anything. So you just let them get better. In chronic Hep B, the algorithms are complicated. But again, what you really want to do, so once you've diagnosed somebody as chronic Hep B, so you wait 6 months and they didn't clear it on their own, or you get a history that suggests the risk factor is really remote, and you're following that patient. And believe it or not, it's the minority of patients you treat. So very different than Hep C and very different than HIV, where everybody gets treated. But for Hep B, what you look for is a bunch of algorithms, but really the two most important things are looking for liver damage and elevated liver enzymes. So if their liver enzymes aren't elevated, you don't tend to be able to help them very much. And so you look for elevated liver enzymes. If they're not 2 times normal, and then in general, we don't treat people. Exception is if you're cirrhotic, because if you're cirrhotic, we assume you may not have much in the way of intracellular hepatic enzymes to spill. So we just cirrhotics we ignore looking at liver enzymes. We just probably treat if there's any evidence of active replication. And so again, how do we find active replication? We look at the DNA levels, we look at the e antigen status, and we do order our serum biomarkers. So remember, the same serum biomarkers or elastography that you would use for hepatitis C. You get your fibrosis score, F0, 1, 2, 3, or 4, or you get your elastography that gives you your liver stiffness, F0, 1, 2, 3, 4. And basically anybody who's starting to get damage, F2 or greater, you treat. So a little bit analogous to how we used to treat Hep C. Anybody on here who's been hanging out with us since 2016, 17, you remember we used to do that for Hep C. We used to treat F3 or greater, but it's F2 or greater for Hep B. We just haven't gotten to the point yet. And the reason is because the drugs are, they're probably, a lot of them are long-term. So this is a little bit analogous to treating HIV. So remember, for Hep C, it's a finite 2-month or 3-month duration where we talk about curing. The treatment approach for hepatitis B is very analogous to HIV, where you put people on treatment and keep them on treatment. And again, remember the treatments, primary 2 drugs that you need to remember is entecavir. That's not a drug we normally use for HIV, and a drug called tenofovir, which you're very familiar with, likely because it's a component of PrEP, HIV PrEP, and also a sort of a backbone regimen of most of our antiretroviral regimens, our combination antiretroviral regimens. And remember, tenofovir comes in 2 types, an old school and 2.0. And the old school TDF and then the new school TAF basically differ in their toxicities a little bit, but in regard to efficacy, they're identical because it's this tenofovir component that's going to inhibit the polymerase of the hepatitis B virus. So there's some older ones. So you probably recognize lamivudine and 3-TC. That's emtricitabine and FTC. So those are also our antiretrovirals that we use for HIV. We don't really like using them for hepatitis B because they become resistant very quickly. And remember, in general, for hepatitis B, we're talking monotherapy. So we'd never treat HIV with monotherapy. We don't treat hepatitis C technically with monotherapy. Remember, with hepatitis C, our Mavorite drug has multiple medicines in it. Our Harvoni, our Epclusa, our Vosevi have multiple medicines in it. But for Hep B, we, for some reason, haven't gotten around to that. So we just use monotherapy. And our monotherapy tends not to be lamivudine or emtricitabine because it works for a very transient time period. So we use entecavir, tenofovir. By the way, in this, if you ever have a patient with Hep B who warrants therapy, look for every excuse to actually give them PrEP. So Kaylee's really good at doing that. She's, a lot of times if the risk factor was drug use or sex, there's some reason that they could probably take HIV PrEP. And so you're already going to give them the patient tenofovir. Why not just give them tenofovir emtricitabine? So you can just give them the combination known as Truvada or Descovy, as opposed to just treating their Hep B. So kind of a cool strategy you can do there. Don't rush to treat your Hep B. Again, that natural history is on your side. But once you do start treating, you really have to make sure your patient stays adherent. So treating Hep B scares me for one particular reason, and it's because if your patient's not adherent to Hep B or transiently adherent to Hep B, when they stop treatment, they can actually get really, really, really sick. So, and that's different than HIV. So if you stop HIV therapy, what happens is, you just gradually start your immune system decay again, but you don't get immediately sick like the next week after stopping your your HIV therapy. If you stop Hep C treatment, it just doesn't work. But if you stop Hep B treatment, it can flare up and kill you. And so I really, really get to know these hepatitis B patients first. I literally make them come and see me like 2 or 3 times just to make sure that they'll come see me 2 or 3 times. So I pretend I forgot to do a lab or two, but actually I usually do because I'm just a dumb clinician. And I don't have Annie in the group. I have in the positive clinic to actually make sure I do my job. So I do forget to do the right labs on occasion. But anyway, I want those patients to come back 3 or 4 times to get to know them so that I know they're gonna be adherent. So, and again, the treatment is open-ended. I usually tell people I don't know if I'll ever be able to stop your treatment. And it's not always true. We can on occasion. If you treat somebody and they start developing the anti-E, so say their E antigen goes away, which is one of the goals of treatment, and then you develop the antibody to E, and there are some people who will treat for about a year after that and then stop and see what happens. I'm usually not that brave. I usually just keep going, especially if they have any liver damage. Again, because if you flare up, you can get quite sick. It's like an acute viral hepatitis. And so if they have cirrhosis, that could really hurt people. So, but just know there are some people you could stop in, but in general, enter the conversation by saying this is probably lifelong. I keep mentioning these flares. What the heck is a flare? A flare is what looks like acute Hep B, but it happens in somebody who has an established chronic Hep B. And the flares happen in certain settings. So remember, when we teach you guys about hepatitis C, that's one of the only black box warnings on the hepatitis C drugs. Remember, the hepatitis C drugs are Epclusa, Harvoni, and Mavorite, and Zepatier, and Vosevi. Super safe, super safe. You can't hurt people with it, except that the only time you can kill somebody with those medicines is if you accidentally treat their Hep C when they had a cult Hep B. And then you treat the Hep C, which was bullying their Hep C around, their Hep B around. And then once their Hep C is gone, the Hep B wakes up. And if you're cirrhotic with borderline liver function as is, that flare can actually cause harm and hurt you. So that's one of those flares, black box warning, why we're always super careful to make sure we don't have co-infected people before treating. And number 2 is the one I'm talking about that's scary. So when patients stop their treatment, they can experience a flare. The other one that's kind of cool, and if there's any PCPs on this call, I always like you to be aware of this one, and it's steroids. So, and it can be a steroid burst for like COPD exacerbation or poison ivy or something like that. Just a minor little blast of a Medrol dose pack can make Hep B flare. Pretty wild. So, and of course you can make it flare in other settings too with more significant immunosuppression. And there's great tables available that kind of rank the degree to which various medicines immunosuppress you and make Hep B reactivation more likely. So I will mention one thing on here. I don't think I have it on here very well. No, I don't. Is even if say you're somebody who has developed immunity to hepatitis B, so you've developed surface antibody. You developed your surface antibody, you're in a good spot, but then someone goes ahead and crushes your immune system insanely. And I don't mean a little dose of steroids. I mean like an organ transplant. or gives you an anti-CD20 agent, that's rituximab, or any of those drugs that really crush all your B cells. Those are given for MS and for some autoimmune diseases and stuff like that. So if you really, really, really remove someone's memories, immune system memory, you can reactivate Hep B even in people who were previously immune. We just had one in the hospital recently, documented immunity, got rituximab. So in other words, he got an antibody that targeted all his B cells, and therefore didn't have meaningful immunity anymore. And that darn DNA virus woke up and gave him an acute hepatitis that actually went into near liver failure. So his INR went up to 3, and his transaminases were over 8,000. So really scary. Bilirubin to 20s. So be careful. Even though in those immune patients, remember this is a sneaky herpes virus in sheep's clothing, so to speak. Okay. I mentioned these kind of ad nauseum. These are the major tests that you're going to order up front, and only if you have a hard time categorizing your patient or any of these are positive, you can add additional testing, such as your DNA and your e antigens and stuff like that. Okay. Then a couple just shifting the paradigm from treatment and stuff like that to prevention stuff and screening and testing. So really the current recommendations mirror HIV and hepatitis C, where we now advocate going above and beyond risk-based testing, because we all know that people don't always know their risks, and they don't always want to disclose their risks. So we want to do actual screening on people, just like we do for Hep C, and be opportunistic, test them during pregnancy and during any other intervention or any other encounter that might imply high-risk behavior, such as encounters for STIs or PrEP or anything else. So test, and vaccinate. The difference between HIV and hepatitis C and Hep B is I shouldn't have to give this talk because we got a good vaccine, right? But you can see up there that we have a long way to go. And yeah, that is what it is. We got a lot of vaccines for it. The new fancy one is down below. The Heplisab is a 2-shot series. So remember, everything else up till Heplisab has been a 3-shot series. You give it the first time you want to give it, then a month later, and then 6 months down the road. And that may be hepatitis B vaccine alone, or it might be combined with hepatitis A. But they're still 3-shot series, and they're okay, but they're not awesome. They're not perfectly immunogenic. And actually, no vaccine is perfectly immunogenic, but there's this new recombinant Heplisab. You can be done by your second shot, which is a month later. So you can give it at month 0 and then come back in a month and get your second one. And it does seem to be a little more immunogenic. And so I do like it from that perspective. So we want to vaccinate anybody who wants it, anybody with risk factors, anybody with chronic liver disease. And the reason there is you don't want them to get another insult on top of their chronic liver disease. So people who drink, and people who have other forms of hepatitis, etc., people with risk behavior, etc. So we just want to vaccinate, look for every excuse. This isn't one I often think about up front. I'm really good at thinking about my pneumovax and flu shots and tetanus shots, and I don't often think of Hep B risks, but we probably should more often and vaccinate, do some catch up on our adults as best we can. And how about those non-responders? I'm sure everybody in their practice has had a non-responder to the 3-shot series. And I feel like nowadays that's something that we almost should assay for. And when we have a non-responder, which would be diagnosed as somebody who doesn't develop their surface antibody after the vaccine series, you can use that new fancy Hep B vaccine and see if you can get them to seroconvert with the new Heplisab. Or you can repeat a different series, but that's what I tend to do, is go to the 2-shot series. So now I'll leave you the last slide is about mother to child transmission prevention. And again, this is one of those things that's really awesome, analogous to our super good success of preventing mother to child transmission for HIV. The strategy is a bit different. You only treat mom with antivirals in the 3rd trimester, unless she has some other indication to be treated otherwise. It's not that the meds aren't safe. That's just when it's most important to do. So if mom needed treatment regardless, you could start her whenever. But if she doesn't meet any treatment indications, which most of the time these young childbearing you know what I mean, young women, pregnant women, there we go. That's the words. They often don't need hepatitis B treatment otherwise. And so if you're just trying to treat them to prevent mother-to-child transmission, you start in the third trimester. And then when baby pops out, you give baby preformed immunoglobulin and the vaccine immediately. And if you do that combination of treat mom and then treat baby, it basically prevents transmission. Pretty amazing. Pretty amazing. Pretty awesome. So and that's it. So that's how it's different. I kind of had those same slides again because that's all I really wanted you to know. But any questions pop up as I'm chatting with anything I didn't address? Well, I didn't address hepatitis D because that's a whole other animal. Look for it. I don't see it very often. Remember, anytime you see a hepatitis B surface antigen, make sure they don't have a D agent added on. We don't have a lot. I can't say I've ever seen it, but one of my colleagues has seen Hep D in West Virginia, so it's coming about. Remember, it's that little defective virus that needs hepatitis B to replicate. So, but yeah, any questions anybody's got? Anything I could explain better or go over any clinical scenarios that we didn't address?